over the past few decades, classic infection has been controlled by rigorous public health measures, and some infections have been eradicated, such as smallpox, by vaccination. The tenacity of bacteria and the resilience of viruses have led to the emergence of new viral infections. With air travel, the geographic barriers of infections have been disrupted, as happened with COVID-19 pandemic. Viruses are now jumping from some lower species to man and causing new types of infections which are emerging. Infections remain an important cause of morbidity in humans. Over the past 2 decades, the Nobel Prize has been awarded to scientists for their discoveries on infectious uveitis. Barry Marshall and Robin Warren, both working in Australia, were awarded the Nobel Prize for their work on Helicobacter pylori. Their discovery of Helicobacter pylori led to the cause of the peptic ulcer, which was important in changing the management of patients who suffered from Helicobacter pylori. Hosen in Germany was awarded the Nobel Prize for the isolation of the human papillomavirus, while Barré-Sinoussi and Montagnier for their work on the discovery of HIV. The Nobel Prize was awarded to Campbell and Amura for their discovery of ivermectin for the treatment of onchocerciasis. And UU2 was awarded the Nobel Prize for her work on artemisinin, which is a new herbal medicine for the treatment of malaria. Last year, 2020, Nobel Prize was awarded to Alter, Houghton, and Rice. Alter was an internist working at the NIH, while Houghton was a virologist who was working at the Chiron and later moved to Washington University in St. Louis, and currently he is in Alberta, Canada, while Charles Rice was at the Rockefeller Institute on the hepatitis C lab. And the award was for their discovery of the hepatitis C. Uveitis can be caused by infections, or it can be non-infectious agents or undetermined due to immune-mediated mechanisms. In addition, masquerade may cause uveitis, that is, such as CNS lymphoma, which may present like uveitis, but in fact it's a malignancy. Now, as medical scientists, we have the unique role to dispel the mystery of uveitis and to replace speculations with certainty and fiction with facts in an attempt to find new ways to diagnose, new ways to treat, and new ways to prevent infections in man. Infectious uveitis can be actually to invasion by the organisms which initiate tissue damage, or it can be self-perpetuating, uncontrolled response leading to relentless destruction of the ocular structures. The infectious trigger may cause immune dysregulation in response to the microbial antigen, and these infectious triggers may sometimes lead to antigenic mimicry and attack of the tissue by the immune system. Ironically, uveitis, which is caused by some infections, and we sometimes use vaccine to prevent them, we find sometimes vaccine causing uveitis. Some of these vaccines, including influenza vaccine, hepatitis B vaccine, human papilloma virus vaccine, MMR, and varicella zoster vaccine, the Zostavax. In addition, recently I had the chance to see one patient who developed vitritis and anterior uveitis 3 days following receiving the COVID-19 vaccine. The association between infectious triggers and autoimmunity is well recognized. Examples are Coxsackie virus and myocarditis or autoimmune myocarditis, beta hemolytic streptococci and rheumatic fever, chlamydia and writers, measles and multiple sclerosis. All these organisms have been associated with some autoimmune disorders in man. Now we'll go over some infections that can present as smoldering, insidious, slow uveitis reactions in man. Brucellosis is one disease which is zoonotic, that is, it is transmitted from animals to man. And there are three important brucellae: Brucella abortus, Brucella melitensis, and Brucella suis. The reservoir are cattle, swine, goats, sheep, and camels. Transmission to man can be by contamination and handling of animal products or by the ingestion of raw milk and milk products. The ingestion of camel's raw milk in Saudi Arabia is a major mode of transmission of brucellosis in man. Gastric acidity kills the brucella, but sometimes we drink milk which can neutralize the acidity in the stomach and becomes a risk factor for the infection with the brucella. Brucella abortus infects cows. Brucella melitensis infects goats. And both of these organisms are important human pathogens which can cause uveitis. There are two phases of brucellosis: the acute phase and the chronic phase. The acute phase may remain for a week or two, while the chronic phase, the organism may stay in man for months and sometimes years, with staying dormant in the tissues, and it sometimes simulates tuberculosis in man. The incubation period of Brucella is 1 to 6 weeks. The onset is insidious with fever, weakness, malaise, aches, lymphadenopathy, splenomegaly, and patients develop hepatitis. Vertebral osteomyelitis may occur in some of these patients. Anterior uveitis is the leading ocular finding in brucellosis. You may have scleritis, rarely keratitis, choroiditis, panuveitis, and vitritis. Brucellosis may present as uveitis only, which can be either granulomatous or non-granulomatous. And we have to keep in mind that brucellosis is both preventable and curable. Uveitis in brucellosis can be anterior, posterior, or panuveitis. Granulomatous uveitis and non-granulomatous uveitis occur. Choroiditis can be multifocal, and retinal vasculitis may occur together with scleritis. Peripheral corneal infiltrates are rare, but have been reported like coin-like opacities or nummular opacities in the cornea. This is a 34-year-old female who has been on treatment for uveitis for 7 years. Patient was on topical steroids and sometimes was given systemic steroids. She was not responding to steroids. And when we saw her, we were able to diagnose brucellosis, and the patient was found to have a paravertebral abscess caused by brucella. And this is an indolent, smoldering, chronic condition, and one has to be careful before the administration of systemic immunosuppressive therapy. This is a patient who presented to us, a 27-year-old male with history of decrease in vision in the right eye. The right eye had light perception and the left eye has 20/20. Pressure was normal. Patient had ciliary injection and KPs with 4+ cells and 3+ flare, and patient had vitreous strands and opacities. We were unable to see the fundus. This is the patient shown here with the changes in the right eye with evidence of injection, and patient had cells, 4+ cells in the anterior chamber. This is the posterior segment. We were unable to look at the fundus. The optic nerve was hazy, and the patient had vitreous strands and vitritis. And this is another view of the vitritis in this patient with brucellosis. The patient did respond finally to systemic therapy, specifically antimicrobial therapy, and had recovery of his uveitis. This is a patient who presented to us with uveitis, and the patient was found to have a paravertebral abscess. It's referred to as Pott's abscess, very similar to the Pott's abscess you see in patients with tuberculosis. These conditions are rare because of the early diagnosis and treatment in these patients. This is a 13-year-old child who was seen at King Fahd National Guard Hospital with bilateral optic neuritis, and the patient had loss of vision in one eye and 20/40 vision in the other eye. And the patient was found to have evidence of brucellosis. Following treatment with specific antimicrobial therapy, the patient had recovery of the optic neuritis. This is important because not all cases of optic neuritis are due to demyelinating diseases, because some are infectious in etiology, and one has to identify this subgroup of patients in order to give the appropriate antimicrobial therapy. Now we move to another group of bacteria that can cause uveitis, and these are also important causes of infectious uveitis. These are the mycobacteria. As you know, the organisms are Mycobacterium tuberculosis, Mycobacterium leprae, and atypical mycobacteria, which are sometimes referred to as the rapid growers, in contrast to the Mycobacterium tuberculosis, which is a slow growing organisms. Mycobacterium even intracellulare complex can cause choroiditis and has been reported in patients with AIDS causing pneumonia. Now, the mycobacteria rapid growers includes Mycobacterium fortutum, abscessus, chiloni, and smegmatis. And the recent nomenclature has placed abscessus under chiloni. So we don't have a separate species for abscessus, but abscessus is a subgroup of the chiloni, Mycobacterium chiloni. This is a patient, a 26-year-old male who had uneventful LASIK here in Riyadh. And the patient 2 weeks later developed loss of vision in the right eye. The left eye had the LASIK flap with normal findings. The patient was found to have evidence of a hypopyon with the buttonhole and the localized infiltrate and infiltrates under the flap. The patient, we lifted the flap and we took the scrapings, which showed acid-fast bacilli, and the patient culture grew Mycobacterium chiloni. He was given specific therapy, and patient had shown improvement 1 week after surgery, after antimicrobial therapy, and this is 3 months later and 6 months after treatment with antimicrobial agents, the patient had regained 20/20 vision. So it's important to identify the organism before you start any therapeutic modalities with antibiotics. Now, the next organism of mycobacteria is leprae. Mycobacterium leprae is endemic in Asia, Africa, Latin America, and Pacific Islands. And we have seen several cases of leprosy here in Saudi Arabia. The organism is an obligate intracellular organism. It cannot survive outside the cell. The natural hosts are humans and the 9-banded armadillo. This 9-banded armadillo, as you can see the leathery armor that he has, and he is the only host that can be infected with Mycobacterium leprae other than man. The animal lives in southern United States, in New Orleans, Texas, and Mississippi, and it is also found in Uruguay and Argentina. It is claimed that this animal was armadillo, the 9-banded armadillo, was in a lab that got infected with Mycobacterium leprae, and one of the armadillos escaped the lab in New Orleans and infected the wild armadillos in New Orleans. Mycobacterium leprae, it's a bacillus that shows a very slow division. It concentrates in cool areas of the body. It does not infect the skin of the abdomen or the warm part of the body, but can grow best at 35 degrees. And as you know, the face is 35 degrees, and it is usually a good site for infection with this acid-fast bacillus. It's a gram stain. It shows dopa oxidase activity, and it can lose its acid fastness by pyridine extraction. Leprosy is of 2 major types. The non-immune type, which is lepromatous form, and the immune type, which is the tuberculoid form of leprosy. Lepromatous form causes skin nodules and thickening of the dermis, as well as infiltration of the earlobes. And it can cause, in the lepromatous form of the disease, peripheral neuropathy, which is sometimes you have destruction of the cartilage because of the infection and it causes saddle nose deformity. The tuberculoid form, which is the immune form of the disease, there are very few bacilli, and the skin is either pigmented or hypopigmented in the tuberculoid form. Peripheral neuropathy occurs in this form of the disease, and this is usually asymmetric peripheral neuropathy, unlike the lepromatous form, which shows symmetric peripheral neuropathy. It can cause facial palsy, it can lead to fifth nerve palsy and chronic indolent corneal ulcer, as well as lid lag. It is one of the major causes of blindness in patients with leprosy. Interstitial keratitis may occur as well as indolent corneal ulcer. The indolent corneal ulcer is due to the fifth nerve palsy and loss of corneal sensation. Patients may develop uveitis, and here there is an interesting finding. This is the leonine facies of patients with leprosy. You can see loss of the eyelashes, loss of the eyebrows because the organism is growing well at 35 degrees. And you can see the saddle nose and the thickenings of the skin of the face. The lepromatous form of the disease may cause anesthesia of the fingers, and patients may tend to burn their fingers and their toes as well. And you can see an area of depigmentation in the skin. And this is a typical manifestation of the tuberculoid form of leprosy, showing areas of pigmentations and depigmentations. And the patients may develop uveitis with posterior synecdoche. And there is one pathognomonic sign in leprosy. It's actually the only pathognomonic sign in ophthalmology, which is the pearl of leprosy. This is what happens on the iris. You get these micro pearls over here. These are small pearls in the iris, and this is a large pearl on the iris. There is no other disease in medicine that causes a pearl on the iris except leprosy, and we call it the pathognomonic sign in ophthalmology. The tuberculoid form of the disease is treated with dapsone, 100 milligrams daily, with rifabutin, 600 milligrams once per month for 6 months. You have to keep in mind, although uveitis occurs in leprosy, rifabutin, which is the treatment for leprosy, causes uveitis as well. So if a patient with leprosy did not have uveitis and you gave rifabutin and developed uveitis, then the patient may be susceptible to the rifabutin and developing uveitis because of the rifabutin. Lepromatous form is given 100 milligrams of dapsone once daily with clofazimine, 50 milligrams once daily, or rifabutin, 600 milligrams once daily. Another alternate drug for lepromatous form of the disease is ciprofloxacin, which can be given 500 milligrams every month for 24 months, and the disease is susceptible to ciprofloxacin. Now we move to a more common disease, which is tuberculosis that can cause uveitis. It is estimated that 1.7 billion humans are infected with tuberculosis. It's 10 million cases per year estimated by the WHO, and 3 million deaths per year. In fact, this disease, tuberculosis, is the most common cause of death in Philippines, And it appears that in Southeast Asia, individuals living there in Philippines and Malaysia and in certain part of Vietnam, the patients are susceptible to infection by tuberculosis. And if the elderly gets tuberculosis, this might cause or lead to death. As we mentioned, 10 million new cases of tuberculosis are noted every year, estimated by the WHO. In San Francisco, there are 11 cases per 100,000, and this is 4 times higher than the incidence of tuberculosis elsewhere, mainly because of a cluster of HIV positive individuals living in San Francisco. Now, X-ray of the chest may be normal except for apical infiltration. The apical infiltration is typical of tuberculosis. You may see calcification, but you may also see infiltration by just plain chest X-ray. And why do you have apical infiltration? Because Mycobacterium tuberculosis loves oxygen and it has to stay in areas where they are well oxygenated. And the apical oxygen is much higher than the basilar uh, forms of tuberculosis, and therefore you can see it more often in the apical form. Although the basilar can cause the recurrences of tuberculosis. Now, scrofula is a disease of the eye, tuberculosis of the eye and neck. And until the 18th century, therapy was the touch of royalty for the king's evil. Scrofula was used to be called the king's evil, and it's caused by tuberculosis. In Shakespeare, Macbeth Act IV Scene 3, it's called evil. This is about the scrofula. A most miraculous work in this good king I have seen him do, whereby the touch of royalty cured the tuberculosis, and this was mentioned by Shakespeare. Strangely visited people, all swollen and ulcerous, pitiful to the eye, the mere despair of surgery he cures, hanging a golden stamp about their neck, put on with holy prayers, and therefore the touch of royalty may be an approach for the treatment of tuberculosis. This is a 17-year-old Yemeni male who came to us because he had red eyes of 6-month duration, only the red eye, and he did not have anything else. He was given topical steroids to no avail, and later he was given systemic steroids, but he was not responding. When he was considered to be given immunosuppressive therapy, he was referred to us, and we looked carefully, and we found evidence of nodules, 1, 2, and 3 nodules in the sclera with evidence of keratitis. And you can see a sclerokeratitis. And the patient had preauricular lymph nodes, so he had neck lymph node involvement. By definition, it is scrofula. And we took a biopsy from the lymph node, which was draining, and it showed caseating granuloma. And you can see here the necrosis, caseation, and evidence of multi-giant cells in the inflammation here. And this acid-fast bacilli were seen and isolated as well. Following anti-tuberculous therapy, you can see that without steroids, we stopped the steroids and we started the patient on anti-tuberculous therapy. And you can see the evidence of decrease in the scleritis and the evidence of scleromalacia associated with it. The interstitial keratitis subsided as well. We reported the clinical manifestations and tuberculous sclerokeratitis with Dr. Shogi and Jarudi, where we found out that patients with tuberculous sclerokeratitis, if given appropriate therapy with antituberculous therapy only, you don't have to give them steroids. You get complete recovery of their sclerokeratitis without anti-inflammatory agents. This is a female patient who came to us with redness of the eye. We found evidence of granulomatous uveitis, and you can see large granulomatous uveitis, despite the fact that this patient was on topical steroids. And when we looked at her neck, there was evidence of swelling and a large cervical lymph nodes. And this was the tuberculosis of the eye and neck. The patients had positive PPD, and the diagnosis of tuberculosis was made. And this patient was given antituberculous therapy. And you can see that after antituberculous therapy, the swelling of the neck is gone, and the patient had complete recovery of her tuberculosis and her uveitis without need for giving systemic steroids. Now, the clinical manifestation of ocular tuberculosis in the anterior segment is sclerokeratitis, interstitial keratitis, as we have seen just now, with conjunctival granuloma occasionally, anterior granulomatous uveitis as well. And you can see a more confluent type of mutton fat keratic precipitates in a patient with uveitis. Multifocal choroiditis, and this is going to the posterior segment of the eye. Multifocal choroiditis may occur, chorioretinitis, retinal vasculitis, and papillitis. Why do we call it chorioretinitis and not retinochoroiditis? We say retinochoroiditis in toxoplasmosis because it starts in the retina and ends up in the choroid, while in tuberculosis, it starts in the choroid and goes back, goes to the inner layer in the retina and causes the retinitis. So it's a chororetinitis. In fact, the choroiditis is much more common in patients with tuberculosis. And as you know, the choroid has 40 times higher oxygen saturation than the retina. And since Mycobacterium loves oxygen, so it has to go to the choroid in order to get the oxygenation required for her metabolism. Retinal vasculitis may occur, and papillitis, and occasionally you might get neovascularization with the misdiagnosis of Eales disease in these patients while they are actually patients with ocular tuberculosis. This is the choroiditis, which is more than the retinitis in patients with tuberculosis, mainly because of the need of the organism for oxygenation. This is multifocal choroiditis. You can see the choroiditis down here and here, as well as here. Multifocal choroiditis should be always considered in the differential diagnosis of choroiditis and caused by tuberculosis. This is a 22-year-old male who presented with decrease in vision in the right eye. This is the right eye. And you can see the juxtapapillary choroiditis and evidence of chororetinitis. Patients had a positive PPD of 25 millimeters, and the patient was started on antituberculous therapy. Here again, no steroids was given, and you can see the choroiditis due to tuberculosis 1 month after treatment, shown here with delineation of the choroiditis This is 6 months after treatment with evidence of early scarring, and 2 years after treatment with antituberculous therapy, you can see the scar formation in patient with chorioretinitis. This is another patient with tuberculosis showing multifocal choroiditis and hyperemia of the optic nerve head. This 28-year-old male from Kuwait, he came to us for another opinion after given treatment in Kuwait, and he went to England where he sought medical advice at Moorfields Hospital. He was diagnosed with the diagnosis of multifocal choroiditis with panuveitis. Someone was given systemic steroids, but he came back to Kuwait and did not improve. He gave history of decrease in vision in both eyes of 1 year duration, and he was given systemic steroids for 2 years, and he was not improving. His chest X-ray and CT scan of the chest were both negative. The only finding in this young man who was healthy otherwise, with normal chest X-ray, is a positive PPT of 25 millimeters of induration. And this is the patient before treatment, and you can see the subtle multifocal choroiditis. Maybe he was immune that it did not progress to that level. And you can see the evidence of multifocal choroiditis. And this is the right eye, and this is the left eye. And this is OD before treatment and OS before treatment. And you can see the fluffy, hazy border of the choroiditis and evidence of early retinitis. The patient also had very early type of retinal vasculitis. Despite 2 years therapy with steroids, he waxed and waned and did not improve with the steroids, and the patient was placed on antituberculous therapy. You can see this lesion here, and you can see the early pigmentation is becoming darker. And if you look at this patient here, this is 2 weeks. This is the patient of the pigmentation. It's a scar in the choroid at the level of the retinal pigment epithelium. And you can see the darker pigmentation occurring with evidence of early form of healing of the choroiditis. You can see the delineation of the choroiditis as well. And this is patient before the treatment, and after the treatment, you can see evidence of scar formation. And you can see this lesion that had scar, evidence of choroiditis and retinal pigment epithelial lesion. You can see a mild vasculitis here, but also you can see the dark pigmentation occurring after healing of the choroiditis due to tuberculosis. Now, biomicroscopy showed the normal anterior segment. It's only juxtapapillary lesion in this patient. This is only one eye. It is the right eye, and this patient had juxtapapillary choroiditis and retinitis. And you can see how extensive it is. This is before treatment, and this is a scar formation after treatment. Again, this patient was given systemic antituberculous therapy. Tuberculosis occurs 80% in the lungs, in the chest, and 20% extrapulmonary. And out of those that are that have active tuberculosis, if you take the cases of active tuberculosis in the eye, 90% of the cases with active tuberculosis have no chest disease. I'm saying this because when I started my career in ophthalmology, I was taught that if you suspect tuberculosis, send the patient to the internist to rule out tuberculosis. And this is what we used to do. We used to send the patients for chest x-ray, pulmonologist to see the chest, and also to take a sputum culture. But if you look at these cases, 90% of the cases with ocular tuberculosis do not have pulmonary disease. And this we have to keep in mind, and not to rely on the internist in making the diagnosis of ocular tuberculosis. The treatment, of course, you know, it is for the active cases, we have to give them quadruple therapy. It's not enough to give 2 drugs, you have to give 4 drugs, and this includes isoniazid, rifampin, pyrazinamide, and ethambutol. Ethambutol can affect the ganglion cell layer and therefore should not be used more than 2 months. And you can continue with isoniazid and rifampin for 4 months. So you can give a total of 6 months, and this is recommended by the WHO. In the latent form of tuberculosis, you can give isoniazid 6 to 9 months, or isoniazid and rifampin weekly for 12 weeks. Keep in mind that isoniazid can cause neuropathy, it can increase the liver enzyme. Ethambutol can cause retinal ganglion cell toxicity. Pyrazinamide increases the uric acid and may cause arthralgias, while rifampin can increase the liver enzyme and causes pinkish discoloration of the urine. This you have to keep in mind or tell the patient before they leave your office. Tell them that the drug that I'm giving you will make your urine look pinkish or red, because patients get scared and call you back to ask you about the changes in their urine. Streptomycin, which we sometimes use, but it cannot be used more than 2 weeks because it can cause ototoxicity. And rifabutin can cause elevation in liver enzymes as well. There are alternate drugs like the 3rd generation quinolones and the 4th generation, moxifloxacin, ciprofloxacin, and the others. And here there are recent reports showing linezolid, which is a drug used for the treatment of staphylococci, can be effective as an antituberculous therapy. So the 4 drugs that we have to give is NIH, rifampin, INH, isoniazid, rifampin, pyrazinamide, and ethambutol. This is a 76-year-old female who presented to me with this appearance of granulomatous uveitis. Patient had positive PPD and positive chest X-ray and CT scan for tuberculosis. We had to admit her to the chest hospital for treatment for tuberculosis. And following treatment, she has complete resolution of the granulomatous uveitis, and the patient had no other symptoms following treatment with tuberculosis. She developed cataracts, and we did cataract surgery successfully, and the patient did well. We did report on the complications of presumed ocular tuberculosis a few years back, and if you want to refer to this, because we don't give steroids except for certain situations. For instance, in immune reconstitution inflammatory syndrome, or ART, it has been shown that you can give systemic prednisone for these patients, especially in patients with vision-threatening lesions, optic nerve lesions, involvement or close to the macula, and evidence of vasculitis. And so in certain cases, we may have to give prednisone under coverage of antituberculous treatment. And This is the first line that we have mentioned, ethambutol, isoniazid, pyrazinamide, rifampin, and streptomycin, while the second line of treatment for tuberculosis is amikacin, capreomycin, ciprofloxacin, levo, and moxifloxacin. And the third line of treatment is rifabutin, clarithromycin, linezolid, arginine, and bedaquiline, which we rarely use. But clarithromycin, rifabutin, linezolid, sometimes we have to use these patients as alternate drugs for treatment of tuberculosis. This is a young 8-year-old girl who presented because the mothers noted a white pupil. This is one eye showing the choroiditis and retinitis, multifocal chorioretinitis. And the patient had vasculitis in this. And the patient had white pupil. It was suspected by the treating physician that she might have retinoblastoma, although late for retinoblastoma. But this patient had a whitish lesion. In fact, it was a uveitis with a panuveitis. And we decided, because this eye was blind and painful, to enucleate this eye. And we did enucleation. And you can see the lesion inside the anterior chamber, the granulomatous lesion, and the patient had evidence of panuveitis as well. This is the ciliary body of this patient showing the gazeating granuloma, and this was a typical case of tuberculosis. And not only that, we took half the section and we minced it and put it on Lowenstein-Jensen medium for tuberculosis, and it grew the typical currently rough colonies over the surface of the Lowenstein-Jensen medium, and this was Mycobacterium tuberculosis. So it's not only proven by PPD, but also proven by culture. And acid fast, they were all acid fast, and you can see them here, the acid fast bacilli taken from the culture. So these are the drugs that we mentioned. Keep in mind that resistance to one or two anti-tuberculosis therapy may occur in 14% of the cases, and resistance to isoniazid may occur in 10% of the cases. Linezolid has been reported for treatment of chronic, extensively drug-resistant tuberculosis. Keep this in mind as a potential drug for the treatment of tuberculosis. And now I will like to conclude with one more organism, which is very interesting. This is a 47-year-old Saudi female who presented with blurring of vision in the left eye. History of fever and malaise, 2 weeks duration. She had 3 cats at home. And the pressure was normal. The anterior chamber showed no cells, no flare, minimal cells in the vitreous and left eye. And she had inferior branch retinal artery occlusion with evidence of neuroretinitis. And this is the right eye. You can see the vasculitis, and there was a small vessel that was occluded here. The rest of the eye looked relatively good. And this is the left eye. And you can see an occluded artery here. It's a branch retinal artery occlusion with evidence of neuroretinitis, with exudates. And if you look carefully, you find a small angioma. I'll come back to this. What's this angioma? Why do you have in this type of... So first we thought that this could be a Bartonella infection. which cause the neuroretinitis and causes central retinal artery, branch retinal artery occlusion. You can see the angioma here in this fluorescein angiography here. And this is the exudates by the OCT, and this is the visual fields. This corresponds to the vasculitis that occurred in the right eye. And you can see the retinal artery that was occluded, causing a sector field loss in this patient. So what we did blood studies, C-ANCA and ANA, and P-ANCA all were negative. The complements were normal, and white count were within normal limits, and patient did not have diabetes mellitus. But Bartonella antibodies, IgG and IgM, were reported. This was very high, IgG 1 in 256. It's usually less than 1 in 128. And Bartonella Hansley IgM was 1 in 20. So this was done at the Mayo Clinic because Bartonella antibodies are not done here in Saudi Arabia, so we had to send them to the Mayo Clinic. So this is a patient with positive Bartonella antibodies and neuroretinitis. The patient was given azithromycin, and the patient had complete resolution. We reported the branch retinal artery occlusion in acta ophthalmologica. And this angioma is actually bacillary angiomatosis. And in fact, when the HIV epidemic started, this disease used to be called bacillary angiomatosis because of the angiomas that occurred in the skin in patients with HIV positivity. We should not rejoice the triumph over classic infection, but we should be prepared for the newly emerging and currently evolving viral infections. We can conclude by saying, to feel is emotion, to think is philosophy, to believe is religion, to know is science. This is said by Tolstoy, and I would like to add to Tolstoy, to appreciate is art. Thank you and have a good day.